I'm going to talk through a paper that we had published fully last year in Research Synthesis Methods, looking at how we can estimate subgroups and interactions in aggregate data meta-analysis. So obviously this is me talking today, but of course this is work that I'm presenting on behalf of my co-authors and lots of collaborators who've helped with this work. So just want to acknowledge them at the start, and I'll acknowledge them again at the end. Okay, so the outline of the talk today, and I'm going to talk probably for about 40 minutes before we've got time for questions at the end. Starting thinking about a single trial, what are subgroups interactions in this setting, then move into meta-analysis and some of the potential problems that you might get to in meta-analysis, something called aggregation bias. I'm going to talk about what our new approach is, what I'm calling the within trial framework, give two examples that show differing things, and then finally finish off with what's next in this for this work. Okay, so if we start thinking about a single trial then, well, the aim of any clinical trial, I would really say, is to estimate some kind of overall treatment effect, overall estimate of the treatment for the average patient comparing intervention to control. Now, of course, trials recruit a diverse population. There is no average patient. It may be that there are some older patients, younger patients. They may differ by sex, by disease severity. So we also want to know whether this overall treatment effect might vary due to these things, these patient covariates. And whether or not the treatment effect varies or not is what I'm referring to as an interaction. So you can see here we have this group of patients and we split them out and look to see, is there a difference in treatment effect between these ones and these ones, between these ones and these ones, and so on. And this is our interaction. So whilst interactions are really great, it's also often important to know the subgroup effects as well. So how good is the treatment effect for this group? How good is it for that group? As well as what's the difference in effect between these two groups? And my focus today really is on participant level factors. So when we move into meta-analysis, I'm not thinking about trial level things like blinding status, risk of bias, anything like that. I'm thinking simply about things that can vary at a participant level. I've given some examples of these here. So just thinking then about a single trial, I'm going to introduce this with a trial called Stampede that's been run at the MRC Clinical Trials Unit where I'm based at UCL. So this trial recruited people with locally advanced or metastatic hormone-sensitive prostate cancer. And it was a MAMS study, so multi-arm, multi-stage. What I'm just thinking about here is the abiraterone comparison. So for the case of this example, we can just think of it as a two-arm trial where patients were randomized either to get abiraterone plus a standard of care or the standard of care alone. And the outcome of interest here is overall survival using the hazard ratio effect measure. So my subgroup of interest is metastatic status of randomization. So where the patient's M0, so that's where they've still got locally advanced prostate cancer, but it hasn't yet spread, or M1, where the cancer started to metastasize. So this is kind of a measure of disease severity at baseline, you could say. This comparison recruited just under 2,000 patients, fairly evenly spread between M0 and M1. And overall, this trial showed that there was a hazard ratio of 0.63, where hazard ratio is less than 1, indicating improvement with abiraterone. So here you could say that with abiraterone overall, across all patients on average in this comparison, there's about 37% relative benefit. And you can see the confidence interval there is quite tight as well. So here now is just this data plotted out. So you can see here the M0 group, which has its own hazard ratio of 0.75, and the M1 group, which has a hazard ratio of 0.61. So remember, hazard ratio here, less than 1 favors abiraterone. And now we're just going to stop quickly for a quick poll, which I think Dario is going to sort out with 5 questions. I just want you to have a go at. So does the effect of abiraterone in the single trial work for all patients, M0 only, M1 only? We don't have enough information, or we don't know, or you don't know. So I'll just give you another 20 seconds or so to have a go at voting for this. Great, lots of answers are coming in. Okay, right. I think I'm pretty happy with what has come up so far. So if I bring this over here, I think people can probably see it, hopefully.
Yeah.
Um, great. Okay, so it's kind of split between three, a few don't knows, but we've got all patients, M1 only, or we don't have enough information. And this is really great. This is kind of what I was hoping for. Um, yeah, I mean, you're tempted to say that yes, it only works for M1 because the M0 confidence interval crosses the line. You're tempted to say that we don't have enough information, and I would say that would be correct, or all patients, if you can interpret that from the plot as well. And I'm going to talk through why. So notice here that the trial was powered just for an overall effect. So when we split patients into subgroups, then you're going to find that there's more variability within those subgroups. Now, this trial actually was targeting a treatment effect that was a hazard ratio of 0.75, which is actually exactly what we had in the M0 group. So the fact that it happens to cross the null line is probably an artifact of the fact that we've now halved the number of patients in that group. So what we really want to look at here is want to look at the difference between these treatment effects. And by doing that, we can we can look at what's referred to as an interaction p-value. So this here is testing the effect or basically testing, are these two subgroup effects the same? And with a p-value of 0.37, there's no evidence whatsoever or no strong evidence to suggest that these subgroup effects are different. So you can see here that in the paper, this really good paper by Spears and colleagues in the Annals of Oncology, which I definitely recommend you going to have a look at if you haven't yet, and it's in my reference list at the end. They're saying there's no good evidence here of heterogeneity of the treatment effect across these subgroups. Now we can go one step further, and we can actually estimate the interaction hazard ratio. So I'm talking about this because I'm going to talk about this throughout the rest of the talk. So what I mean by this doesn't just tell us is there a difference or not? Is there statistical evidence for a difference? It actually quantifies this. So what an interaction hazard ratio here, if you haven't seen it before, is it's a ratio of our hazard ratios. So this 0.81 here is 0.61 divided by 0.75. So an interaction is always with respect to a reference subgroup. So this means that basically our best guess is the relative benefit of abiraterone is about 19% greater for M1 patients, so 19 comes from here, than it is for the M0 patients. But you can see the uncertainty around this. It could be 50% better, or it could be 1.33 times worse. So we don't have statistical evidence here to say that there is a difference between these groups. Great. Okay. Moving on now to meta-analysis, where we're just going to generalize those ideas across multiple trials. So here's just a Cochrane review I found when I was preparing for this talk, published last year, looking at convalescent plasma for people with COVID-19. And on an outcome of 28-day mortality, this here is an example of a subgroup analysis, looking at whether or not antibodies were detected at baseline. So we have two groups, antibodies detected at baseline group and the no antibodies detected at baseline group. And here, this is the antibodies detected at baseline group and the 5 trials here that had patients in that group. What the approach they've done here in this review is they've done a mini meta-analysis of these 5 trials, and that gets a subgroup effect as shown. And then the same 5 trials, but of course different patients. This bottom one here is now patients where no antibodies were detected at baseline. And again, they've done a mini meta-analysis of these 5 trials to give us a subgroup effect here. Here now they can compare these two effects for a test of interaction or a test of subgroup differences. They mean the same thing. And here you get a p-value of 0.13. So there's not really any strong evidence of a difference, but it is suggesting that maybe there is some small differences, or maybe you would see a difference with more studies. And I'm calling this the subgroup first approach, because if you notice, we care about the subgroup first, then we get the trials involved. Now, this is an example which hopefully is familiar to you. You should have seen these kind of plots before. So now what I'm going to do is I'm going to move on to a toy example to try and persuade you that things can go wrong with this approach. So this is an example now, completely different, where we have three trials, and this is a very extreme example just to demonstrate what can happen. So we have three trials, trial 1, 2, and 3, and here the covariate of interest is disease severity. So each trial recruits patients with low severity and with high severity, and you can see that trial 1 is mostly low severity because of the box size, and trials 2 and 3 are mostly high severity. So now let's have a look at the subgroup first approach. And to estimate the subgroup effect for low severity, we do a mini meta-analysis of these three estimates to suggest that actually there's quite a large beneficial effect of the treatment for low severity patients. For high severity patients, we do this mini meta-analysis of these three, and this suggests actually there's null effect. There's no real effect for these high severity patients. So now if we want to estimate that interaction, we're taking the ratio of these odds ratios, and I'm just putting it on the right-hand side for ease, and I'll keep presenting it in this way throughout. And you can see there is statistical evidence in this toy example of mine that there is a greater effect for low severity patients, you can see that here, than there is for high severity patients. So what could be wrong with this? Well, if I add on the weights to this plot, you notice that this approach is using a different set of trial weights for each of our subgroups. So 80% of the weight for the low severity patients comes from trial 1. Well, in actual fact, only 10% of the weight for the high severity subgroup comes from trial 1. So if there's potentially any trial level differences between trial 1 and trials 2 and 3, this could be causing confounding. So it could be that trial 1, let's say, has a different standard of care, or maybe a slightly lower dosage of the treatment because in general they recruit lower severity patients. And it could be these differences that in actual fact are driving the apparent difference we see here between low and high severity. So this is what we mean by aggregation bias. So aggregation bias is where trials that are imbalanced in severity, so you can see trial 1 is mostly low severity, look different to the other trials where trials 2 and 3 are mostly high severity. And this is potentially causing this trial level confounding that might be introducing a spurious interaction effect when it might not exist. So let me now show a different way of looking at this with exactly the same trials and exactly the same data. So this is just, instead of subgroup first, this is what I'm talking about, I'm going to refer to as trial first. So notice we have the same three trials, but now we're actually looking within a trial instead of before we were looking within a subgroup. So this is mirroring what I showed you at the start when we were looking at an individual trial. So this was popularized in this paper by colleagues in the BMJ. And if we look at what we can do here, we can work out that interaction or ratio of odds ratios within trial 1, which is suggesting there's no difference between these two. We can look at trial 2, again, suggesting no difference between these two. And again, we can look at trial 3, again, suggesting no real evidence of a difference between these two estimates. So now what we can do with these three interactions within each trial is pool them in a meta-analysis, giving us our pooled interaction, which is suggesting actually disease severity isn't an effect modifier. It isn't varying how the treatment works. Now let's just compare that to the result we got from the subgroup first approach, and you can see just how wildly different these things can be and the impact that aggregation bias can have on our meta-analysis and on our subgroup effects. So now let's just have a look at the trial weights, and notice the weights that go into the interaction. There's actually, each trial just contributes one weight to the interaction. So there's no across trial information that's being introduced here. So there's no possibility that trial level confounding can actually impact this. And that means our interaction is bias free. So this approach gives a bias free interaction. But notice we don't get subgroup effects. All we get at the end here is an interaction. With a subgroup first approach, by design, we got subgroup effects. So we don't have that here. So we know, is there a difference between the treatment effects Sorry, is there a difference between our subgroups? We don't know how good the treatment is for subgroup one and for subgroup two. So just to kind of recap then, that subgroup first approach, because it's actually using both across and within trial information, means it's at risk of aggregation bias. Whereas our trial first approach only uses within trial information, which means it gives us a bias-free interaction testing. But because we're not getting subgroup effects with the trial first approach, which ones should we use? Well, why don't we just use the subgroup effects from the subgroup first approach? Surely that's an obvious solution. Well, these actually are valid estimates of effect, but as soon as we start comparing them, so as soon as you put them in a plot where you can compare them, even just implicitly, you will start to introduce aggregation bias. And of course, as consumers of reviews, exactly what we want to do is to compare them. And also, they're not necessarily going to be compatible with the within trial interaction. The ratio of odds ratios between our subgroup first approach won't necessarily equal our bias-free interaction. So this isn't really ideal. And really, we do need a new approach to try and get some additional subgroup effects that make use of our within trial information. This is what's leading me on to talking about our new paper. And we kind of developed this within trial framework is what we're referring to it as, to do three things. Firstly, estimate within trial interactions across any type of categorical covariate, so not just a binary category. And then really importantly, to estimate subgroup effects that are compatible with these within trial interactions. So that we have the most reliable estimates of treatment effect for each subgroup, and then also to try and clearly present this data together on a forest plot. Okay, so for completeness, I'm just going to introduce some of the mathematical components here, but then after this, I'll move on to some examples. So imagine we have a meta-analysis of n trials subscripted by I, so I goes from 1 to n, and a covariate with k subgroups subscripted by j. So for our disease severity example, k is 2, it's low and it's high. So beta ji is the observed effect in subgroup j of trial I. What does that mean? So beta 1,1 is the effect for low severity patients in trial 1. Beta 2,1 is the effect for high severity patients in trial 1. And beta 2,2 would be the effect for high severity patients in trial 2, and so on. We can just have a vector of these effects for each trial. So this is just follows on nicely from that. And we can actually fit a standard multivariate meta-analysis model, which is based on a simple multivariate normal distribution to these vectors, to these beta i's. So these are the subgroup effects in each trial. This here is our pooled subgroup effects we're trying to estimate in this model. SI is a covariance matrix. And here we can incorporate heterogeneity if we want to. So we can model the between trial variability if we so wish. And actually, just applying this model to our subgroup data will give us those subgroup first subgroup effects that I talked about at the start that are risk of aggregation bias. So this model actually isn't doing anything revolutionary. This is actually very standard. I'm just writing out mathematically. So next we can think about a model for our interactions. And our interaction is always with respect to a reference subgroup, for example, low severity. So here we have a vector of k-1 elements. So remember, we have k categories. So we have k-1 elements because, of course, they're all with respect to that reference group. In this case, say the reference group is 1. So we have beta 2i minus beta 1i all the way down to beta ki. So the kth category minus that reference group. So looking at our disease severity example, k is 2. So we have a single interaction. So gamma 2i, which is equal to beta 2i minus beta 1i. What does that mean? That means in every trial, we have a within trial interaction that's telling us the effects for high severity minus the effect for low severity. Or if on the ratio scale, it's divided by. We can actually also fit a standard multivariate meta-analysis model to this data. These are the interactions I've just spoken about. Here, this is our pooled interaction effect we're estimating. VI is a covariance matrix that's actually directly derived from SI from the model before. And again, we can incorporate heterogeneity into this model if we want to. And this actually is exactly what I showed in that trial first example, where we're pooling those interactions on the right-hand side. So both of those previous slides, those previous models, are actually just standard models. And the real key bit to this framework is this kind of linking with the model for the subgroup effects with the model for the interactions. So we're defining what I'm referring to as a compatibility relationship, where these betas here are now our floating subgroup effects. So this is something new. Beta 1 is the pooled effect in the reference group. We just have a vector of ones just for mathematical completeness. And this here is our pooled within trial interaction that we've estimated from that second model. So what does this mean? Well, let's work through this with an example. So our disease severity example, we have low severity beta 1, high severity beta 2. So working through this is equal to the low severity is equal to the low severity, great. And the high severity is equal to the low severity plus our interaction. And remember, our interaction is the effect for high minus the effect for low. So of course, the maths works out nicely here. And what this relationship means is that the difference between our subgroup effects is equal to our within trial interaction. And that's exactly what we wanted to do. So just to quickly talk about random effects, I've mentioned that we can incorporate them in both of those models. So for the model for the interactions, the model for the subgroups, and there are three different kind of considerations here. A fully common effect approach, where we just set these matrices to 0 and we don't model any of the heterogeneity in our subgroup analysis. We can introduce exchangeable random effects, where basically this setting, we have a single parameter for the subgroup effects and also a single parameter for the interactions, which may be 0. Or we could go and actually allow unstructured random effects, which basically allows a different heterogeneity variance to be estimated within each subgroup and within each interaction. So now I'm going to talk about how we implement this method in practice and look at some specific examples after I've just worked through a toy example to add some clarity. So there are 3 steps to this. First, we estimate the interaction. Secondly, we estimate the subgroup, floating subgroup effects, our betas, constrained by our interaction. And finally, we have a little bit more work to do to actually correct the variance because we haven't incorporated some of the error in step 2. So this is a new example. This is new trials, new data, all made up. But I'm just using this example to now, where there is an interaction, to show how the method works in practice. So we have 3 trials again. We're using disease severity again, low and high, just for ease. And also for ease, these trials are all made to be the same size. So just so it works out a little bit easier for this example. Okay, so step 1 then, what we're doing, remember, is we're working out that interaction, the difference between our subgroups within each trial with respect to a reference group. So in this case, it's low severity. So what we do is we take these 2 odds ratios, take the ratio of those 2 odds ratios, and that gives us our interaction odds ratio of 2. So this is equal to 0.5 divided by 0.25. So it's a ratio of those 2 measures. For trial 2, we do exactly the same. 0.63 divided by 0.29 is equal to 2.21. And for trial 3, 0.7 divided by 0.39 is equal to 1.81. And of course, there's variability associated with this that I'm currently ignoring how to calculate, but it is by standard approaches. The final part of step 1 is pooling these 3 estimates in our meta-analysis. As I've said, they're all contributing the same weight just for ease. And we see here that our pooled interaction is works out exactly as 2. So on average, low severity patients get twice the benefit of treatment that high severity of patients get. And, you know, that makes sense. You can see all the low severity patients are further to the left than the high severity. Okay, so now step 2, and this is where it gets a little bit more complicated. So in step 2, I've split this into 3 bits. Here we're estimating our floating subgroup effects constrained by the interaction. And what we want to do is we want to scale the non-reference data by the pooled interaction. And I'll show you why we do that shortly. So we have our pooled interaction here, which is 2. So we scale the non-reference data, which is high for each of our trials, by 2. So divide each of these by 2. So for trial 1, the scale value is 0.25, and you can see this estimate now coming to the left, which is mirroring exactly what it does for the low group. For trial 2, 0.63 scaled is 0.32. This comes again to the left. Not exactly the same as it is here, though, because our interaction was different from this one. And for trial 3, we scaled to 0.35. And again, it's not exactly the same as seen because the interaction in that study was 1.81. So what do we have here now? We have the reference subgroup data for each trial, which is unchanged. And now we have the non-reference subgroup data for each trial that's had the interaction applied to it. So it's been scaled to look more like the reference data. So what this means, it means statistically, we now have a set of values, all these 6 values, that we can interpret as estimates of the true underlying treatment effect in the reference subgroup, which is low severity. So what we can do now, so all of these, we now can pull this all together to estimate the reference subgroup. So we're using our unscaled reference subgroup and the non-reference has had the interaction applied to it, all to validly estimate an effect for the low volume patients. And you can see all of this together brings us in a multivariate meta-analysis the low severity subgroup effect. So importantly, this is ensuring that all the available data is used and also that the trial-specific weighting is identical across our subgroups. So now in part 2C, we now want to estimate the non-reference subgroup, the floating value, using that compatibility relationship. So remember that the compatibility relationship was that the non-reference data was equal to the reference subgroup plus our interaction, or on the ratio measure, times our interaction. So here we have 0.3 times our interaction of 2, and our effect for the high group comes out as 0.6. So you can see, of course, the ratio of these two is exactly equal to this, because that's what we've ensured happens. And we've used all of our data to come to this point. So finally now, step 3, we need to do this little bit more work to correct the variance. And this actually can be calculated using a formula. It's fairly straightforward, but not quite as simple as a standard formula. But of course, in reality, we'd use computer software to do this. And you can see just for each estimate, they get a tiny little bit wider. So we have now the variability in these two groups. So you can see importantly in this example, whilst there is evidence of a difference between low and high disease severities, it actually looks like the treatment works for both of them quite convincingly. So whilst we might prioritize treatment for low severity patients, we wouldn't necessarily be saying it doesn't work for the high severity patients. And that's what we get from the subgroup effects. Okay, so some of the key features then, hopefully I'll persuade you that this approach gives us bias-free interactions and subgroup effects. And we can do it for any type of categorical covariate. I'll show you one of 3 levels shortly. And really importantly, we can do this with aggregate data. We don't need IPD. All you need is actually the same amount of information that you need to do the subgroup first approach. So you just need an estimate of effect within each subgroup, within each trial, and the corresponding variability. It uses all of the available data when estimating subgroup effects. And this means that studies I'm referring to as single subgroup trials where they only recruit patients in one subgroup can be incorporated. And there's potentially some controversy about that. That does require an assumption, and I've got some appendix slides to maybe talk about this if we have time at the end. We can model heterogeneity, and also we've developed some software available in Stata, which I'll briefly mention at the end as well. Okay, so now just to take stock, I'm going to go through a couple of examples. This first one just to demonstrate the method in action. So this is from the stopgap docetaxel meta-analysis that was published last year in the Lancet Oncology. And this included 3 trials where the patients were people with metastatic hormone-sensitive prostate cancer. They were randomized either to docetaxel chemotherapy or the standard of care, which in this case was androgen deprivation therapy or ADT. The outcome here is progression-free survival using hazard ratio effect measure. And we've got two subgroups we're going to work through. The first, which is volume of disease, which is binary, low and high. So basically, high volume just means that the cancer has spread more. And subgroup two, which is clinical tumor stage, where increasing T stage is basically increasing bulkiness of the primary tumor. Okay, so this now is volume of disease. So you can see this is a real example. This is similar to what I've shown you before. We have our three trials as follows, and the effect for low volume here, and the effect for high volume in each of our three trials. So you can see in each of the three trials immediately the effect of docetaxel, so less than 1 to the left, it looks like it favors high volume more than low volume just from eyeballing this plot. So the first stage, we just take the ratio of these hazard ratios as follows. So point, and then we do the same for Chartered, the second trial. You can see the ratio of these two giving us 0.6, and do exactly the same, the ratio of these two giving us 0.87. Then we do our meta-analysis of these three estimates. But before that, you can just see one of the benefits of this approach. You can now, as people who are familiar with systematic use of meta-analysis, we can look at the consistency between these three estimates and find the second one Chartered is a little bit more extreme than these two. But the confidence intervals of all three are overlapping. They're all pointing in the same direction. They're all saying the same thing, that the effect of docetaxel is greater in high volume patients. So this is a really important feature and part of the presentation that we really like. So pulling these together in our meta-analysis, and just as I said about the consistency, we can estimate heterogeneity statistics associated with this meta-analysis of interactions. You can see here I-squared of 2.7% and a p-value for heterogeneity from Cochrane's Q-test of 0.36. So there's no evidence here of inconsistency in this meta-analysis. Let's have a look at our estimate. So our interaction hazard ratio is 0.76 and a small p-value. So this is saying that in actual fact, the effect of docetaxel does vary based on volume of disease, and actually it's more beneficial for high volume patients compared to low volume patients by about 24%. But we don't know again, how good is the treatment for low volume patients? Does this mean we shouldn't give low volume patients docetaxel? And that's where the subgroup effects come in, that second and third part of the method. And you can see these estimates here, actually fairly similar conclusions to my little toy example. You can see that it does appear to still work for low volume patients. It just works much, much better for high volume patients. And this is a real example. And this is why it's really important to actually estimate these subgroup effects as well. Okay, so just to move on to a slightly more complicated example. This is looking at clinical tumor stage. So now we have three categories. So K is 3. Our reference group here is the top one, T1 to 2. And so now because K is 3, we have two interactions for each trial. We have T3 versus T1 to 2, interaction 1. And we have T4 versus T1 to 2, interaction 2. Let's look at the T3 interaction first. So we do exactly the same as I've shown you before, taking the ratio of these two hazard ratios for each of our trials, and then just do a meta-analysis of those three. Now for the T4 compared to T1-2 interaction, see we're using different data now, still the reference, but we're using the T4 data. We do exactly the same for each trial and pull these three to give us our estimate here of 0.54. Again, you can look at heterogeneity statistics, nothing really to say here. Just to show how the method works for three subgroups, that second stage, I'll take it in steps now. We scale all of the T3 data by the T3 interaction to make it look more like the reference subgroup. So all of that, the interaction here is 0.81. We'll shift a bit to the right because we're divided by 0.81. And then we scale all of the T4 data by the T4 interaction. So all of this will shift 0.54. Basically, all of it will double, so shift quite considerably to the right. And then what we'll have is we have three values per trial that we can interpret as genuine estimates of the true underlying treatment effect in the reference subgroup. Using all of this data together, we can estimate the reference group, which is as follows. And then using that compatibility relationship, We times this by that interaction one by the T3 interaction, which is 0.81 to give us the estimate for T3, 0.7. And we times this reference value, 0.86, by our T4 interaction, 0.54, to get the estimate in the T4 group of 0.46. Okay, so hopefully that kind of solidified how this method works in practice. So now I'm going to move on to an example where there is aggregation bias and look at random effects as well. So this is looking at nodal status in the PORTS meta-analysis, which was published in 2016. It was a Cochrane review. And this included 11 trials that included patients with non-small cell lung cancer and randomized either to post-operative radiotherapy, which is PORT, or no PORT. The outcome here is overall survival using the hazard ratio, and the subgroup I'm interested in is nodal status, N0, N1, and N2/3, where basically greater nodal status means increased lymph node involvement. Just of note here, the reference group was chosen to be N2/3, but it doesn't actually matter which reference group you choose. The maths works out exactly the same. So what I've done here is I'm just showing the pooled estimates, just showing the summary effects. So there's a trial level plot that goes behind this with 11 trials in. And I'll actually show that on the next slide. But this is our approach using our within trial framework, what we estimated. And actually, if you just look at the subgroup first approach, which was one of the original analyses done, you can just see how there actually are some differences here. So the subgroup first approach basically is suggesting, if we look at the N0 group, that PORT is adversely affecting the survival of these patients with N0 disease. When in reality, when we do our approach, you can see we're estimating this near to null, much similar to the N2/3 subgroup. And actually, if you look at whether or not there's a trend between these categories, you actually see the subgroup first approach finds a significant p-value of 0.034, suggesting with increasing lymph node involvement, it actually does modify the treatment effect, whereas we don't see that using our approach. So actually, in some circumstances, this aggregation bias can lead to quite different results that can genuinely impact on patient treatment decisions. So why might there be a difference here? So what's going on? Well, this is the trial level plot, and there's a lot happening here, so I don't expect you to take it all in. But what I want to highlight here is two of the trials. So we have the Belgium trial here and the Lille trial here. Now, this is what I was mentioning earlier when I said single subgroup studies. So these here only recruited patients with N0 disease. You see, they don't have estimates for N1 or N2/3. And actually, in fact, that they've both reported quite large detrimental treatment effects. So under that subgroup first approach, these trials quite heavily and directly influence those subgroup effects. Whereas using our within trial framework, the influence is far more indirect, as they're not contributing to the pooled interactions and actually only being used to estimate subgroup effects constrained by the interaction. So we're much happier with this approach. Just to briefly look at random effects, everything I've been doing so far is all fully common effect approach, just for ease. So of course you can see here, sorry, I should say, this is what I've shown you already. You can see here that tau squared is estimated as 0 throughout. If we fit an exchangeable structure, then you can see we have that one scalar shared across our subgroups of tau squared, which is 0.62. I'll just highlight that there. And you can now see that our estimates from our within trial framework approach are all a tiny bit wider compared to common effect, because obviously they're now incorporating the variability. But the point estimates remain roughly the same. But when we actually fit a unstructured model, unstructured approach, you can see that actually really interestingly, there's substantially more heterogeneity in the N0 subgroup. So now we're allowing there to be different heterogeneity variances for each subgroup. You can see this is far higher in the N0 subgroup. And this causes the N0 estimate to be really quite considerably different and to have a really wide confidence interval, which is reflecting what I showed you from the graph before, the extreme estimates in this subgroup. So conclusions here aren't actually changed, but this is just an example of showing how random effects can be applied. Okay, so just to finish off then, I want to talk about what's next. Um, so first of all, I want to think about presentation. So I've shown you this plot already, and it's mad. There's a lot going on. This here is three categories with 11 trials. Now imagine what happens if you had 20 trials or if you had 5 categories in your subgroup analysis. It starts to become really quite complicated to display this information nicely. So here's an example from a meta-analysis published in JAMA in 2021, where we had 27 trials included, so a lot of trials. Here we had a binary subgroup, but because it was quite hard to display this information easily, we moved to just presenting summary effects. So you can see here, this is the subgroup effect for the no corticosteroid use, and this is a subgroup effect for the corticosteroid use, and we're presenting the interaction here. We still had the trial level plot in the supplementary material, but the benefit of this is now we can actually include lots of things on the same plot. So instead of just including one subgroup analysis, we actually, for different outcomes, could include the same subgroup analysis 9 times across the board. So these are some of the benefits you can have by just using slightly different implementations of these plots. And of course, we had the trial level plots as supplementary material for each of these. Just to quickly talk about multiple subgroups and outcomes. So this is similar to the plot before. This here, we have one outcome where we're looking at 3 different covariates. The top one, we have 4 categories in that subgroup. And you can see now that actually we could repeat these summary effects for outcome 2 and again for outcome 3. So I'm just showing you here that by just using summary effects, you can show more on the same plot, which could be useful for clinical decision making, looking at all those outcomes together. Okay, so just to talk quickly about continuous covariates, everything I've talked about so far is kind of binary or categorical. We don't really want to categorize things like age. You know, we don't want to have to split it at 50 to use our method. We want to be able to estimate personalized treatment effects across that entire age spectrum, maybe even model non-linear relationships, for example. You can't do that using the method I presented today. But we have got ongoing work, which we've generalized actually that builds on the ideas I've spoken today and from these other references here, that actually can generalize it to continuous covariates, but it does need individual participant data. And finally, just to talk a bit about software, we currently have it available in the Stata, and it's on my to-do list to try and get this programmed in R. And yeah, we have 2 software packages, the MetaFloat package that people have been using in Stata, and the IPD float package that's under development at the moment. This is all on GitHub. And just as a snapshot, this is what it looks like in Stata. This here is actually the port example, and we have help files available. But yeah, we would like to kind of continue to develop this in other software packages. Okay, so just to conclude, and thanks so much for listening, I appreciate it. I hope I persuaded you that subgroup analysis is important, and it really does tell us whether or not a treatment effect may vary. And you know, this is really what patients and clinicians want, and it can impact on clinical decision making. But trials lack power to look at this, so you're really unlikely to find something conclusive or definitive in a trial. And so that means that meta-analysis might be really our only tool to reliably look at subgroup analysis. But with meta-analysis, we have this additional issue of aggregation bias that a single trial doesn't have. And I presented today a method to ensure that you get bias-free interactions and compatible subgroup effects with these bias-free interactions. And all of this can be implemented using aggregate data, and also spoken about how we can present these ideas on forest plots. Just want to acknowledge all of my co-authors, David Fisher, Jane Taylor, Ian White, and colleagues who've helped with this work, and all of our collaborators who, you know, we've been testing this methods on them, and that they've done a lot of work on this. And of course, the funders who, you know, without them, this work wouldn't be possible. And just pause for questions. Thank you very much for listening. Further details on the screen, the GitHub page with our software there, and our paper if you're interested. Thank you very much.